Today we're going to discuss cardiorenal syndrome. Thank you for tuning in. We're going to do this through a modern lens. The central idea is that the heart and kidney fail together not because of low forward flow, but because of venous congestion, neurohormonal activation, and end organ pressure interact in real time. The real world dilemma is a creatinine bump during diuresis. A very common mistake is to stop diuresis the moment the creatinine rises. In a congested heart failure patient, that reflex can be harmful. A modest rise in creatinine during effective decongestion may reflect hemodynamic change rather than structural tubular injury. Forward flow fallacy versus venous congestion. The older model blamed worsening kidney function mainly on low cardiac output. The modern paradigm reminds us that elevated central venous pressure and renal venous congestion are often the dominant drivers. Preserving the output without relieving congestion may not protect the kidney. Hemodynamic chokehold of congestive kidney failure. When venous pressure backs up into the kidney, renal interstitial pressure rises. That reduces the transrenal perfusion gradient and opposes glomerular filtration. In other words, the nephron becomes mechanically suffocated even before there's true intrinsic renal injury. The vicious cycle. Neurohumoral and inflammatory cross-trap. Cardiorenal syndrome is not just plumbing. Low output and congestion activate the renin-angiotensin system, the sympathetic nervous system, vasopressin, endothelial dysfunction, and inflammatory cytokines. Those responses then worsen sodium retention, fibrosis, and further congestion, creating a self-amplifying cycle. The type 5 CRS matrix, the Ronco classification, helps organize thinking. Type 1 is acute heart failure causing acute kidney injury. Type 2 is chronic heart failure causing chronic kidney injury. Type 3 is kidney injury provoking heart failure. Type 4 is chronic kidney disease driving cardiac dysfunction. Type 5 reflects a systemic illness injuring both organs together. Deconstructing the creatinine bump. Rose-AHF is important because worsening renal function during aggressive diuresis was not associated with classical tubular injury biomarkers in the study. That supports the concept that not every kidney rise during treatment equals structural AKI. Some patients are simply becoming effectively decongested and hemoconcentrated. Hemodynamic WRF versus structural AKI. At the bedside, ask what pattern are you seeing? Functional worsening of renal function usually comes with improving congestion, ongoing urine output, stable injury biomarkers, and hemoconcentration. True structural AKI is more likely when congestion persists, urine output falls, diuretics fail, or the patient is in overt hypoperfusion or shock. Foundational treatment is decongestion first. The treatment target is euvolemia. Persistent congestion is more dangerous than a small transient bump in creatinine. The DOSE trial taught us that adequately dosed intravenous loop diuretics work and that what matters most is getting enough drug on board to achieve brisk decongestion. Escalation staircase. Overcoming diuretic resistance. When loop diuretics are not enough, escalate thoughtfully. First, optimize the loop dose, then add a thiazide type agent to block distal sodium avidity. Consider acetozolamide for proximal blockade. Ultrafiltration should be reserved for select refractory cases rather than use as a first reflex. Sequential nephron blockade. This slide explains why combination of diuresis works. The nephron adapts segment by segment. If you block only one side, sodium can be reabsorbed downstream. Sequential nephron blockade targets multiple segments, including proximal tubule, loop of Finlay, distal tubule, and mineralocorticoid pathway. Phenotype strategy. Right heart failure deserves special attention because the right ventricle is preload dependent. Yet, excessive filling rapidly turns into systemic venous hypertension. These patients may need hemodynamic guidance, careful decongestion, avoidance of over-aggressive ultrafiltration, and efforts to reduce right ventricular afterload. Phenotype strategy. Advanced CKD and diabetic cardiorenal syndrome in patients with advanced chronic kidney disease, or diabetes, undertreatment is often the bigger mistake. Guideline-directed therapy should not be stopped reflexively. SGLT2 inhibitors, non-steroidal MRAs such as finerenone, and optimized loop therapy can still provide important renal and cardiovascular benefit when monitored carefully. Decongestion is kidney protection. The goal is not to protect a single creatinine value during the admission. The real goal is to relieve the venous congestion, restore renal perfusion pressure, and create a hemodynamic environment where disease-modifying therapy can be continued. In that sense, successful decongestion is kidney protection. The golden rules of cardiorenal syndrome. 3 rules summarize the first half of the talk. Number 1, contextualize the creatinine. Number 2, target the venous side. Number 3, keep asking whether the patient is still congested, still perfusing, or whether another cause of AKI is present before giving up on diuresis. Mastering vexus in the cardiorenal syndrome. Now we move to vexus or venous excess ultrasound. This is a major step forward because it shifts us from guessing at volume status to directly assessing systemic venous congestion. It is especially useful when the exam and IVC alone feel incomplete. The myth of forward failure. Vexus reinforces the same lesson we saw earlier. The kidney often suffers less from isolated low forward flow than from backward failure. Elevated venous pressure raises renal interstitial pressure and impairs function. So, we need tools that capture congestion, not just perfusion. The limitation of IVC alone. A dilated IVC is not the whole story. It may reflect hypovolemia, pulmonary hypertension, athletic baseline physiology, or right heart failure. IVC size helps estimate right atrial pressure, but does not tell us how much venous congestion is actually damaging the organs. Enter the 4-step Vexus dashboard. Combine IVC with organ Doppler at hepatic, portal, and renal veins that lets us transform a vague impression of volume status into an objective congestion score that better tracks end organ stress. Step 1 and 2, the gateway. The first step is the IVC. If it is small, you stop because severe venous congestion is unlikely. If it is dilated, you proceed to organ Doppler. In the hepatic vein, normal flow favors systole over diastole. Systolic flow reversal suggests severe hepatic congestion. Step 3, the gut or portal vein. Normally, the portal vein flow is continuous with minimal pulsatility. As congestion worsens, pulsatility increases. A portal pulsatility index of 50% or greater suggests severe gut congestion, which is clinically relevant because bowel edema can worsen oral absorption and diuretic resistance. The Vexus diagnostic matrix. The score integrates IVC and organ Doppler findings. Grade 0 is normal. Grade 1 means mild congestion. Grade 2 reflects one severe organ Doppler pattern. Grade 3 means multiple severe patterns and identifies patient with marked systemic venous congestion. Fluid management, this is where Vexus becomes clinically actionable. Grade 0 is a green light for fluids if needed. Grade 1 is a yellow light where net neutral balance may be safest. Grade 2 or higher is a red light, meaning the patient is fluid intolerant and usually needs decongestion rather than more fluid. Vexus in cardiorenal syndrome. Higher Vexus grades are associated with acute kidney injury and worsening renal function. Mechanistically, congestion impairs delivery of loop diuretics to the nephron and raises renal interstitial pressure. Breaking that cycle through decongestion can improve kidney function and symptoms. Beating diuretic resistance. A very practical point is that patients with severe Vexus often have profound diuretic resistance. If the congestion score remains high and the clinical picture fits, a modest rise in creatinine should not automatically stop treatment. Persistent congestion is often the more dangerous signal. Beyond the volume, the cardiac connection, Vexus is really a measure of fluid tolerance, not just fluid quantity. A patient can have a negative fluid balance and still show severe venous congestion if the right heart cannot accommodate venous return. That is why the cardiac phenotype must always be interpreted along the ultrasound finding. Conclusion. The new standard of care. To close, physical examination and IVC assessment alone are not enough for many complex heart failure patients. Venous congestion is central to cardiorenal syndrome. Vexus offers real-time, non-invasive quantification of end organ congestion and can help personalize fluid and decongestive therapy.